Sorry, we got booted off. We're back on. This is Dr. Linda live from New York City with Dr. Gregory Levitin from New York City.
Deja vu.
Deja vu. We just want to make sure you guys can see us and hear us. So if somebody can just post, I'm going to go on and see if it's popping up on our page. Let me just check and see if it's showing up on our Vascular Birthmarks page as live. Let me see. I'm not seeing anything.
Yeah, there's some people showing up right there.
Oh, yeah. Renee is on, and April. Yay. Thank you. Thank you. Thank you. So let me just pull it up on here. So, yep, I see us. Okay. I just want to see our live feed, because if I can't see the questions, there we are. Okay. There we are. So we have 4 comments. Hi, Jody. Oh, gotta turn my volume off. Jody's on. Hi, Jody. April's on. Hi, Roy, Britton. Hi, and we see you. Okay, thanks, everybody. So we're excited. October 12th is our conference in Irvine. Yep, and Dr. Levitin will be one of our world-renowned expert surgeons that will be there. You'll be able to have a free clinic appointment and hear his lectures. I think you're talking on
port wine stains and hypertrophy and surgical therapy.
And also let everybody know where your 2 practices are.
So I'm based out of New York City, where I work full-time, and I have a part-time office in Los Angeles that I go to, and people can reach me on my website at birthmarkcare.com or as an Ask the Expert on the Vascular Birthmark Foundation.
Great, thank you. So I can see, you see here, the questions are showing up, but they're not showing up on here, so I'll have to...
There's comments right there. If you look at your comments.
Oh, there we go. Thank you. Jeez, you're even technically not challenged, so thank you. All right, well, we are ready to take your questions. Kristen's on. Hi, Kristen. Cassie Cesares, she said she can hear us. Cry Chris says hello. We have 60 minutes. Now we actually have 57. We'll give you an extra for when we got booted off. We'll go over. So let us have your questions. Any questions concerning vascular birthmarks or anomalies? Dr. Levitin has been practicing about, what, 15 years now? Or
almost 18.
Almost 18.
Yeah, it's been coming up a long time now.
Yeah, wow, time flies. This is our 25th anniversary. We start this October and we go through till next year.
Yes.
So everybody coming to the conference in Irvine in a few weeks, you'll be listening to some of our 25-year stories. Sherry Arnold is on. Corinne is on. Olga is on from Russia. Hi, Olga. Good to see you. Your friend is here. Dr. Levitin did baby gazelle surgery, and we just participated in doing a little video, and we now have that. I sent it to our people to load on our YouTube channel. Of course, it's all in Russian, but our part's in English at the very end. So it's all
I'm sure they got it right. So.
Yep. So let's see. Waiting for some questions to come in. Sherry Arnold. Hi, Sherry. She's on now. Not seeing any questions yet. So, and that's okay. Sometimes it's...
So we can talk about it. Like, so...
Oh, okay. Here we go.
Yeah.
Renee, when treating a venous malformation of the orbit involving the optic nerve, what treatment do you suggest?
Exactly. Well, of course, every birthmark is different. So an MRI is the necessary evaluation to determine the full extent of the venous malformation. And certain areas around nerves, particularly the optic nerve, we actually think of these as potential sclerotherapy treatments with bleomycin. And bleomycin seems to be very effective. It may take more than one treatment to treat the venous malformation that's contained within the orbit. But sometimes we also want to look at the procedure as a debulking procedure. So sometimes we do a combination of sclerotherapy, sometimes a little bit of surgery. It really depends upon the full extent of that. But bleomycin has been incredibly successful and effective in orbital venous malformations.
But I'm assuming too, because the orbit is such a sensitive area, should be an expert, right? In dealing with these.
In fact, it's almost always a combined procedure with a interventional radiologist and a birthmark surgeon or oculoplastic surgeon. Really, people who've done it before. You know, I certainly wouldn't wish that to be someone's first case. But if you can talk to another expert, if there's another specialist out there, I'm always available by email to other doctors who have questions. So the main thing is to do what's best for the patient.
Amen to that. So Sherry wants to know, can venous malformations of the neck cause thyroid issues?
So venous malformations can be invasive. They most commonly involve the skeletal muscle of the neck. So they may involve some of the muscles of the neck. And in that case, they can surround the thyroid tissue. Sometimes they can invade into and around the thyroid tissue. But the fortunate thing is that we don't need a lot of thyroid tissue to behave properly, meaning that you wouldn't necessarily have to go on thyroid replacement. I think that the effect of a venous malformation would be a side effect to the thyroid. And you'd have to, again, evaluate this on an MRI or an ultrasound to see whether or not the thyroid gland is actually invaded by the venous malformation or just surrounded by the venous malformation. And more importantly, is working closely with an endocrinologist who will be measuring the blood factors, the thyroid hormones, the thyroid stimulating hormones. And, that's a case-by-case basis.
Thank you. Cassie says, I'm glad you all have been able to share and make aware all kinds of hemangiomas and different types. My small town was not knowledgeable at all, and it took 3 doctors to diagnose my baby correctly. Thank you for the awareness and being able to spread the knowledge.
Sure.
Good stuff. Sherry Arnold says, since diagnosed under active thyroid and taking levothyroxine,
levothyroxine,
yeah, my VM has spread. Well, that's really interesting because there's that hormone issue too.
I was say, so all types of vascular malformations can be stimulated by hormones. That could be, puberty, it could be adolescence, it could be pregnancy. With a synthroid or an exogenous source of thyroid hormone, which is a metabolic hormone, that is definitely possible. I would say that that's something you should definitely bring up to your endocrinologist and perhaps to your birthmark doctor. And certainly on the side, you can certainly send it to me directly as well. Sometimes you have to follow it up with an MRI evaluation now and maybe 3 months later to kind of see how things have changed over the interval. If it's visible and you think it's changing, I think that's definitely a possibility. So we should certainly, stay in touch with that.
Great. So you can see we have 41 people on now, so it's really picking up. Erin wants to know, can you have a venous malformation and not see anything visible? With FALA, I know you can, those fibroadipose vascular anomalies and some deep ones too, right?
Venous malformations are often start within the skeletal muscle. So a lot of the most common areas are like the jaw muscle called the masseter, or extremities and some of the muscles. When they break out of those areas, they invade into fat and even into skin. And I think, again, every case is going to be individual, but certainly a lot of times the first sign that I see someone with a venous malformation is pain, because the venous malformation dilates or stretches or swells the involved muscle. The muscle has C fibers in the fascia around it, and that's what gets triggered or stimulated to cause pain. And then you have to do a full workup, which includes, again, an MRI evaluation with contrast. And that's when you discover the malformation, which may not be visible, meaning not all malformations have a cutaneous or skin component. And that's what makes the art of diagnosis, important. Just as someone said, just because you don't see it doesn't mean it's not there.
True. So Nazreen made a comment. She said, Dr. Linda, I want to say hi and thank you for being kind and helping me in my daughter's case when we thought it was a hemangioma, but it was cancer. Thank God she's getting better. That was one of the cases that I referred as it did not appear to be an infantile hemangioma, right. And we always have to be aware of that.
Well, I think in infantile tumors, the most common tumor of infancy is a hemangioma, which is a vascular tumor but benign. But it can also appear or mimic a reddish type color, and something called a rhabdomyosarcoma can be a type of pediatric cancer. And so either a biopsy or an MRI can usually determine whether this is vascular or a hemangioma, or if it has a muscle appearance, which would be within the rhabdomyosarcoma. And those of us who are in this field long enough, it fortunately doesn't come up regularly, but it's one of those things, thank God, that it's one of those things that you always have in the back of your head, particularly one that doesn't look like a classic hemangioma.
And also some of those KHE, those Kaposi cases have like a malignant tendency to them.
Well, I think they act like a cancer, even though they're treatable in that regard. But yes,
so
those are
that's
others,
why it's important to have an expert.
It's called Kaposiform hemangioendothelioma.
Yep. So we have quite a few questions. Kristen wants to know, her husband wants to know, when lasering her son's port wine stain in the jaw area, would he be able to grow a beard?
So port wine stains change the texture and architecture of the skin and the dermis. And the hair follicles sit in the dermis layer. The port wine stain is stained on the cutaneous or epidermis layer. And so the pulse dye laser only penetrates through that epidermis. But because the malformation is full thickness in that dermis layer, sometimes it stretches or it replaces some of the architecture, so you get less hair involvement. It's not because the laser did it, it's because the malformation, the port wine stain, grew into those tissues and basically destroys or replaces the hair follicles. Different than that is the YAG laser. Now, the YAG laser is used typically for venous malformations, but because of the depth of the YAG laser, which is much deeper than the pulsate laser, yes, that YAG laser can actually destroy the hair follicles because it's treating the dilated veins in that dermal layer, which is the same location as the hair follicles. So when I talk to people who have venous malformation in hair-bearing areas, which could be men in the beard area, but even men or women in the eyelid area, where we'll be trying to get the purple color away, but you can accidentally take out the eyelashes. So you have to be very careful about that. So
it's really important.
These are good questions, though.
Gabrielle says her daughter has a hemangioma under the eyelid, but not affecting the eye. She's on propranolol. Does this seem like an accurate treatment for a 9-month-old?
So this is a hemangioma of the lower eyelid.
Yeah.
And so, yes, I think oral propranolol is absolutely the right first choice. I think if there's skin involvement, you should consider doing laser treatment at the same time. But if it's a deeper one, as you said, underneath the skin, but really involving the orbit, 2 things. 1, propranolol, but 2, also regular follow-ups every month or every 6 weeks with a pediatric ophthalmologist to check for astigmatism, and that means whether or not the globe is being compressed by this hemangioma, and also measure whether or not it's getting better or getting worse, which will determine whether or not we are seeing improvement. The most important thing about a orbital hemangioma is that if you're on propranolol, that the astigmatism is getting better. Because if it doesn't get better, if it's held and it's out asymmetric, meaning it's much worse than the other side, those are actually indications for surgery. And that surgery should be done before 12 months of age, ideally before 9 months of age, because if it's treated and reversed before 9 or 10 months of age, the eye will actually develop correctly. Between 9 and about 13 or 15 months, the surgery will help, but it may not go back 100%. And if you wait till after 15 months and do the surgery, even though you remove the pressure, the eye has actually already developed in an infant so much that the eye does not go back to normal. So this is a critical time to evaluate whether or not it's being effective.
It's so frustrating.
It is, and I'll also say we treat propranolol works about 65% of the time. I mean, in a beautiful way. But for those 1/3 of patients, you have to follow them closely because sometimes the propranolol just is not as effective as we want it to be, and we haven't quite figured out which ones do the best. But we certainly want to watch those patients closely.
Yep. Well, we have tons of people writing in now, and Cry Chris has FAVA, the fibroadipose, and he got diagnosed at Boston's, but he's from Europe. I do have a doctor in Europe, so email me directly. Dr. Laurence Boone in Belgium is treating these, so if you want to email me, I will get you that information because he's saying they're recommending embolization and will it be helpful, but there's just a lot of controversy around that. So.
Well, it also depends upon the vascular component because an embolization requires a vascular inflow, and sometimes these are soft tissue tumors, which can actually be treated surgically. Sometimes they will respond to the embolization. I certainly haven't seen the scan, but I'd be happy also to add it.
So Oka's saying there's no propranolol in Russia. That's like shocking. Like it's even the generic should be there. I mean, what about all the heart disease?
So it's my understanding that they don't have the liquid form of it available. So they often take the tablets and crush it, and it's very careful. My only concern about that is the consistency of the formulation because we do not want to overdose these children. These are normal children who are being treated with a cardiac medication. And I think if there would just be one company that, in Europe that would provide liquid propranolol, like I said, in a carefully, formulated suspension, that would be a great win for those children. Because the children, I get emails sometimes about, how, well, the pharmacist will crush it and make it into a solution. And I think that's technically, in a compounding pharmacy, that's correct. But I worry about how consistent that formulation would be.
Maybe we can talk to Pure Farb about this, getting them into Russia. I like to talk to them. I'll be seeing some of their reps at our conference next month.
That's a great discussion, and I'm glad. Thank you for bringing that up. Whoever wrote that.
So Kevin McGrath is watching. That's Julia's dad. So Alona Novaksky Wilson, her daughter with a upper lip. Lymphatic Katie has it. Yeah, well, she's saying now during her period it flares up.
So that's a lymphatic malformation, and it is definitely responsive to
hormonal
changes.
Steroids and antibiotics?
you want to avoid that during a monthly interval. You may want to talk to a pediatric endocrinologist, because sometimes, as much as you don't want to talk about it, sometimes the oral contraceptive pill can normalize vascular malformations that fluctuate during hormonal cycles. And so as early as age 14 or 15 is an appropriate age to have that discussion with an endocrinologist.
And the other thing is, Ilona, Dr. Levitin and the whole team will be there in a few weeks, and we still have openings for the clinic. So maybe you and Katie can come. We'd love to see you. It's Saturday, October 12th. We can get you in the clinic. Please just, sign up and come. Renee has another question about the bleomycin, because she's got a pretty extensive VM. I don't know if you remember her from the days with you and Milton. Dr. Wayner, she's had surgeries in Arkansas, surgeries in New York, and it's pretty complex.
Sure. Well, I think what it really matters now is what is left behind.
Well, she's worried about alcohol and paralysis in her face.
Yes. But what I really meant to say is that anyone who presents to me who's had previous treatment, it's very helpful to know what kind of treatment you've had, but it's really more important to evaluate what you have now, because what I'm trying to decide is, are there other treatments that could be effective and safe? And I think that the way to do that is to have a recent MRI evaluation with contrast, and that should show up where the problem lies. And if we can match the disease and the symptoms, then I think those are patients who are worthy of treatment. And sometimes, the safe thing is to do nothing, because these are incredibly, important structures, the eye, the orbit, any nerve. Mm-hmm. And that should be evaluated on a case-by-case basis.
Okay, well, tons of questions coming in. So Jody Lee wants to know why there's such a discrepancy amongst doctors with treatment protocols, and why do some doctors not know anything at all about it? And that's a subject question near and dear to my heart.
What I would say is that vascular birthmarks are their own specialty. And I say that is there are doctors who are truly interested, passionate about it, who study it, who go to conferences, who unfortunately are able to see enough patients to get the experience necessary. And the classic example I'll say is, you can go to the best plastic surgeon in St. Louis or Denver or Raleigh and not necessarily see the best birthmark doctor for you. And I say that meaning that people can be well trained and even have good intentions, but if they don't have the experience and the background training, and more importantly the diagnostic skills to differentiate between the different types of vascular birthmarks, well, they could be the best trained person, but they're just not the best vascular birthmark doctor. So it's not that doctors don't know anything, but they're only able to diagnose what they see or what they study. Mm-hmm. And this is just one of those things that was a little bit of an orphan disease for many years. Mm-hmm. When my own daughter was born, I had a textbook that told me what to do, but it certainly didn't tell me the right thing to do. I had to discover that on my own, and as many other patients find out that their local pediatrician or even a local dermatologist who has only seen one or two or three may have just a limited experience. And so again, it's not to judge those doctors as much as to say is, well, share your experience, reach out and see what other doctors can do. Certainly the Vascular Birthmark Foundation, we have a lot of experts who are willing to take your emails, attach a photo, mm-hmm. And those are the kind of ways that you find information. And information, knowledge is power, and that's what really we're up here.
And that's why we exist, to try to close that gap between physician to physician and patient to physician. Ida Hajakabari said, "Thank you for your time. What is your idea about gene therapy? What do you think about stem cells for venous malformations? Is it going to be a cure?"
So gene therapy, you can almost call it hot off the presses. So I think the most recent studies that I had seen were gene therapy borrowed from, I believe, the melanoma treatments, where they were able to block some of the angiogenesis pathways. But specifically, I saw it in reference to arteriovenous malformations. And I think that we're going to see some interesting talks at the conference. And I think that there are people who literally, this is the entire focus of their study. And so I'm excited to learn from them as well. But I think that this is we're just starting to learn that there may be some pathways. Fortunately, the ISFA classification of 2018 further classified or subtyped certain types of vascular malformations by their genetic markers. And so I guess you could say we understand it a lot better, but I think we're just developing better treatments for those kind of things. But I'm very excited about the future.
So Olga asked another question, and if she says we don't have propranolol, what else might there be? I mean, it's a beta blocker, and
so there is something called atenolol. Atenolol is an example of a medicine that we sometimes give patients who develop asthma-type symptoms or a cough on propranolol, which means that they're overly sensitive to that alpha receptor, and so I think that's his beta-2 receptor. But those are case-by-case basis, working with a pediatric cardiologist. They often have the most experience with beta blockers to kind of guide us through what other formulations may be available. There are some online pharmacies that I would use your doctor, to help navigate those with you. And there may be ways to order these medications online. I'm not an expert on that. I'm based in the United States, and we don't have mail order pharmacies. But when someone's trying to do what's best for their child, who would do whatever it took to get the care for their child, I would certainly, open that avenue as well.
And again, I'll talk to Pierre Farb at the conference. Maybe we can get something. Shay has a great question. How do you control pain due to an ulcerated hemangioma in a 10-week-old? Lidocaine and Tylenol around the clock aren't cutting it.
So the first thing when I hear about pain from an ulceration, I worry about infection. So I think it's very important to make sure that there's no signs of infection. That would be redness, erythema, any discharge more than just from the broken skin. There's also a couple other therapies that we have for wound care, and I believe there's some wound care guidelines that should be on the Vascular Birthmark Foundation website that I was part of a long time ago, and we can certainly update that. There are some silver-based formulations. Silver-based is like silver nitrate, Silvadine, which is what we use for burn patients. It creates an artificial biologic barrier, which can sometimes help prevent infections and pain. And the most important thing is wound care, because our goal is to get those ulcerations closed, and that's really what's going to ultimately treat the pain. And I think that it requires a wound care specialist, and that is something that I'm happy to take emails from directly as well after this.
Yeah, and Dr. Darrow's been using Meta Honey. Have you heard about that?
Manuka honey.
Manuka honey.
Yeah, Manuka honey has, it's considered, there's a lot of people think it has a lot of medicinal properties. But I am, for the purpose of medical therapy today, I think it's meticulous wound care, and also oral propranolol. I've seen some, and sometimes even laser therapy can help hasten that process and make things heal up much quicker. But you're certainly in for a good 2 weeks and maybe a little bit longer. And I think careful with topical lidocaine, because that can be absorbed through an open skin in an infant, and that can be a dose-dependent thing that we don't want to get too concerned about. So again, be careful about topical lidocaines. But I think that Tylenol is safe to give around the clock every 6 hours. It should be weight dependent. There's infant drops that show weight recommendations, quarter to a half medicine dropper, and that can be very effective as well.
Great. Erin wants to know if the PDL can reduce and maintain any tissue hypertrophy. Does it affect?
Yeah, and so we try to treat laser therapy early on in port wine stains for hypertrophy. I assume that's where the question is going with port wine stains. And YAG laser can go even deeper than the pulsed laser. The pulsed laser really treats the cutaneous color, and it's really the standard of care for port wine stain management at an early age. And we are looking at patients who we've been treating since literally from day of life onward, meaning children who've been treated in the first few months of life aggressively for the first few years of life. Both Dr. Nelson and Dr. Dranos have shown excellent long-term control. I think when children get to adolescence, it can change again. And then we also know that the biological behavior of port wine stains is that over time, about 15% will develop tissue hypertrophy, some earlier than others. And I think we're still learning, when we talk about biologic markers or genetic predisposition. But yes, port wine stains can reduce the overall progression. YAG laser can help treat the deeper component, which may be causing hypertrophy. But that's really the best we have right now.
So Christina Chabinidze, she was one of your patients. She just wanted to thank you.
I know Miriam. Yes.
She said thank you. Yeah. She's just wanted to say thank you for everything you've done. Emma
send
Carmichael, send them a pic. Recommended treatment for 15-month-old, and I think I remember seeing this online with the pyogenic granuloma on the pinea near the ear canal.
So usually, pyogenic granulomas are a vascular tumor which have biological properties similar to a hemangioma. They occur from a scratch or an insect bite where a break in the skin causes a vascular stalk to grow into it, and it develops like a little raised area. And if you catch it early, the pulsed laser, like a hemangioma, can sometimes reduce it. But when it's growing quickly and it cannot be cauterized, it actually has to be excised and then allowed to heal, either by stitches or even secondary intention. And I would see a ear, nose, and throat specialist. That should be someone that should be able to take care of this. It's something I see regularly in my practice, but it's not a dangerous thing, other than if left untreated, it will continue to grow.
So Susan has problems with her calf and her leg muscles where her port wine stain is, and she wants to know if there's anything that can be done about that.
Yep. So port wine stains, I always like to remind people, are full thickness lesions. So what I mean by that, malformations that occur not just in the skin, but in the fat, in the muscle, and the bone. And so when you have a full thickness area and that gets swollen or engorged, you're talking about the calf muscle, which is right behind, below the knee. When we are standing upright, a lot of that blood pulls in that area and it causes a significant amount of swelling. And I think that swelling is what's causing the pain. So we think about it, compression stockings, and again, do medium strength. These are the same type of compression stockings people use when they go on planes. You have to get that 15 to 25. It can't be that 10 to 15 low, but it has to be the medium grade. You can also do neoprene sleeves that can be custom compression stockings for that. But if you're experiencing daily pain and you're having to take pain medications, then I think absolutely that would be the way to go, is to try to develop compression therapy and some sort of medication that will help improve that.
And we also talk about the hydrotherapy, the swimming and the circulation.
Yeah, so activities that improve the blood circulation, that get that venous stasis out of that area would be very helpful as well.
So Cassie, the name of the laser Dr. Levitin was talking about is the neodymium YAG, or
neodymium
YAG, ND-YAG.
Yes.
That she just wants to avoid it. So this is from, it says Dave Tanis, but it's his wife. And Tricia, I have a port wine on a significant portion of my right leg. The only time I've ever had issues is with pregnancies, which was simply sore. Now at 48, in the last couple of weeks, I've had pain when I bend my leg greater than 90 degrees. Would you describe some of the changes that might take place as I age? So she might also be a little perimenopausal too, having some hormone changes.
So I would say if you've had changes during your pregnancy, that means you've had hormonal fluctuations of your port wine stain. That means you've had progression. And progression, again, can be full thickness. Full thickness can involve areas in the muscle and fat. And I would say that also, as the son of a rheumatologist, there are other things that can cause joint issues. Things like popliteal cysts, Baker's cysts. And so I would say that you should be evaluated by a knee specialist, whether it's a rheumatologist or a orthopedic surgeon, but to evaluate whether or not there's something else. And typically we do MRIs, and the MRI with contrast will show if this is part of the vascular malformation or perhaps one of these other conditions. But pain is definitely something that you should be evaluating, having this evaluated by a doctor.
Thank you. A lot of people on. It's really great. It's like firing like one right after the other. So Heather says her 17-year-old son had multiple pulse dye laser treatments at Arkansas Children's over his left eye and inner arm from 1 to 8 and had great results. Haven't treated since and getting red again. Is it too late for more pulse dye laser to have a good result?
So I'm going to again assume that this is a port wine stain if you're having multiple treatments through adolescence, and that if you're having return, what I like to always say is we do a really good job when they're young, but then they grow. And as they grow, the malformation can grow. But it's not a failure of the treatment. It just means that from time to time, you're going to need to have interval treatments. So it's never too late. In fact, I've had 50-something-year-olds that have come back in for laser treatment where we get right back to where we were. And then basically, you want to treat the port wine stain with another series of lasers, roughly every 6 weeks. And you should see step by step progression or improvement in the stain. And once you get to a comfortable place, you can take a break for another several years. It sounds like you had many years of stable, port wine stain. But just over time, it's expected that it will continue to grow just a little bit. And from time to time, you may need to have some additional treatment.
Thank you. Amber says she has an AVM in her right shoulder, elbow, and chest, and it's causing pain.
So, when you have chest wall or extremity arteriovenous malformations, this can be triggered by trauma, even just, regular daily activities. I think that it's very important to have an MRI with contrast. I think it's important to see an interventional radiologist who may do a diagnostic angiogram to see the full extent of this. And more importantly, if they can see the good arterial inflow and outflow, there may be single vessels that can be treated that can potentially reduce the pain. And I think that this is one of those case-by-case things that you have pain, you should be evaluated by a specialist who can evaluate the extent of the malformation and determine what the appropriate treatments would be.
Perfect. Daniela said she'll see us at the conference. She has KTS. She just wants to know if it's safe to keep taking aspirin.
So people with KTS of the lower extremities is where I think she's going with this, have an increased risk of deep venous thrombosis. So people who go on planes, or even just who are stationary, meaning not ambulating or walking enough, they have a slightly increased risk of pooling of blood in these dilated veins, increased risk of blood clots or deep venous thrombosis that could potentially travel and cause into their lungs. So usually they are seeing a hematologist or a KTS expert, and are usually on a low dose aspirin therapy, and also again compression stocking down planes and certain other precautions. And if you ever had a history of a deep venous thrombosis, then you would have additional treatments like a filter or something to prevent future clots, even a blood thinner. But again, those are definitely reasonable precautions to take.
Melissa says, does antibiotics and steroids help with flare-up of a venous lymphatic malformation? My son has never been offered this, and we actually are seeing the doctor this week because of pain.
Yeah, so venolymphatics are mixed malformations. They have a lymphatic component and also a venous component, but it's really the lymphatic component that is the exacerbating cause of the pain and infection. And when you have those exacerbations, it can be from a dental cleaning, it can be from a local trauma, or even just aggressive toothbrushing, or sometimes just a systemic infection. Then those are the ones where you want to nip them in the bud. You do want to take a broad spectrum antibiotic and a short course of steroids to get back down to the baseline where you're not having flare-ups anymore. And unfortunately, for 2 or 3 times a year, this comes up a lot of times in adolescents, but also again in adults. But yes, medical therapy can definitely treat this without the need for other therapy.
Great. I've never heard this question from Cassie. It's a follow-up question. She wants to know if we've ever seen seizures triggered after weaning a child from propranolol. The baby was on it from when it was days old to 2 years old. Could that be related?
So, propranolol is a cardiac medication that affects the heart rate, and I would say that could this have been unmasked? Meaning there are pediatric seizures that occur, in epilepsy and things like that. I would definitely go see a pediatric neurologist and have this evaluated, quickly. There are medications that when the child has had a seizure, if it's a single seizure, whether it be a febrile seizure, it could have been an illness-related seizure. They'll discuss that with you, whether or not this is related to something incidental, or whether or not it's potentially systemic or something that the child may grow up with. But specifically, propranolol works really well in the early proliferative phase or growing phase of hemangiomas. After 12 to 15 months, the effects are much less, and certainly something to discuss on a case-by-case. If there's regrowth, or if there's a prolonged growth period, you can potentially treat longer. But in general, I don't think that longer is better for propranolol. So it's certainly reasonable to come off, but that is not a side effect profile that I'm familiar with or have heard of.
Thank you. So Gabrielle said, hi again. We're seeing a pediatric ophthalmologist for our daughter's eye every 6 to 8 weeks.
Perfect.
Her astigmatism seems to be getting better each time.
Good.
It just seems like her hemangioma is still just as purple and puffy as it was at birth. Would I have to worry about her vision being affected if she were to have laser surgery? Her current doctor at University of Michigan said she would want to avoid surgery, and said they probably wouldn't be able to get the entire hemangioma.
I would say, for the sake of this discussion, please email me afterwards with a photo and maybe a progression of your photo, so I can fully evaluate that. If you've had an MRI, I'm happy for you to mail me a CD to review that. A lot of patients do this for me. I'm happy to offer my opinion. And you're at a critical time, so I think this is the right time to ask these questions. And again, I think they're covering you with the best medical therapy, but the real question is there anything else that could or should be done at this time? And I'd love to just have a one-on-one conversation with you once I've seen some more information, some photos, to give you some better information. So please reach out.
Great. And you'll see in this string. And by the way, this video will be able to be reviewed 10 times if you want to. They stay on our website and our YouTube channel and our Facebook page. And Dr. Levitin's email is posted in the comments section. And you can also reach him through our website. So Jen May said her son has a scalp complex VM in the brow temporal area. Can these lead to migraines?
Absolutely. So it can be a trigger for migraines because the malformation, the venous malformation, has a dilation component. And when it occurs in the frontal muscle or in the frontal area, it can certainly cause swelling and pressure and pain that can go. Also, it may involve deeper into the eye muscles as well. And the strain can lead to migraines. So yes, I have several patients who've had forehead and eyelid venous malformations that had pain complex or triggered migraines. When we treated or debulked these, 80 to 90% of the headaches or pain goes away. So I highly recommend you consider treatment for this, even if it's stable, because people who suffer from headaches know that it's a random day when you wake up and you don't know if it's going to be a good day or a bad day. It can really affect your quality of life, and I highly recommend that you have this evaluated.
Thank you. I think Rishma might have to send you some pictures because she's saying, can a lip hemangioma that is not grown since the baby is 4 months old start growing after the baby is 1?
So this is one of those examples where do we have the diagnosis correct? And it's so important to have the correct diagnosis because all treatment, or all, whether it be treatment of observation or treatment of propranolol or laser or surgery, has to be depending upon the diagnosis. So again, I'm happy for you to send me some photos from birth to now and review those for you. And again, I would really just like to have more information to give you that kind of reassurance and that confidence of knowing that we're doing the right thing.
So Lauren wants to know what your thoughts are on timolol.
Yep. So timolol is a beta blocker gel. It was originally a ophthalmologic medication, meaning that people who used eye drops that had beta blockers for other reasons, glaucoma. And so the timolol gel works in some cases, but the some cases that it works on are the ones where you have very thin skin. So the eyelid skin, sometimes the skin around the nose or on the ear, those are the kind of thin areas where timolol can be effective. I think it's also effective when you use it with laser therapy. So I think it's one of those things on a case-by-case basis, but it's not a heavy lift. So if you catch it early and you're doing some laser therapy and you want to add additional therapy, I think timolol is great. It's not instead of propranolol. So if you have a thicker or larger area, especially inside the orbit, you really need to move on to oral therapy quickly if you see growth. But in that early stage, if you have one of those lucky ones that's not aggressive or it's just a flat, red stain, absolutely try the timolol, but please try it with the laser therapy because I know they work better together than waiting for one and then the other.
I call that the early 1-2 punch to knock it off course, because if you can get them at 2, 3, 4 weeks and use that combo, you can really save,
So absolutely. I mean, we like to treat them on the day of life, not like month of life, but on the day of life. And I just had my first opportunity to treat a child on day life 4 or 5 on an early hemangioma, stunted it right then. Never came back. It's one of those great opportunities.
Done by one. Done by 1 week.
Done
by 1 week.
Exactly.
That's right.
But
still one.
But Linda, you just mentioned a good thing. With that 1-2 punch, we talked about timolol and laser. Propranolol and laser is equally effective. And I think it's been shown, I think Dr. Geronimos had put out a great publication where children who are treated with laser and then propranolol, or people who are treated with propranolol and then laser, had longer therapy. Sorry for my dramatic show, but people who were treated with laser and propranolol had a shorter duration of therapy, both less frequent lasers and less time on propranolol. So there's definitely something synergistic there. It's definitely worth taking all the options and putting them starting right off the bat.
I get so many of these. So Jennifer Rafkin is writing in. A lot of the babies have the big hemangiomas on the top of the scalp.
Yeah.
And she wants to know what are the risks of removing it?
So this is a great question. It's also the kind of thing that even before I see these patients, they've already had a major workup and everything like that. Could it be connected to the brain? Is there something that's going through there? And I just want to remember, hemangiomas are implanted along the epidermis-dermis junction. So they are superficial or cutaneous tumors. And when they grow down through the dermis, they grow down to the loose tissue surrounding the skull. And while there may be draining blood that comes from this that goes in through the draining veins of the scalp and the skull, they do not connect to the brain. It just doesn't happen. And there are many patients who've had MRIs that prove my point. It's not just my expert opinion, but it's, like I said, it's been proven time and time again. And even over a fontanelle, there's still a layer of tissue. And if you are meticulous in your dissection when you do the surgery, because we're talking about large hemangiomas of the scalp that often need surgery, and you want to operate on those children earlier because the elasticity of the scalp is so much easier to remove a large hemangioma, but then take a scalp and stretch it closed without having to do tissue expanders or waiting until the child is older or anything like that, because that early opportunity is much, much more effective. But they do not connect to the brain. You can do an ultrasound if someone's truly concerned, just more for reassurance. But an MRI is usually a child under sedation or anesthesia, which is really, in my experience, just not necessary. And I'm happy to, on a case-by-case, someone across the country to, for their doctor to reach out to me. Are you sure, Dr. Levitin, is this really what's the truth? And I'm happy to tell you that that's just not, it does not connect to the brain, no matter how close it may appear to the brain.
She's a good one to send a picture to you.
Please
really
reach out to me.
Opinion.
I think my email should be somewhere available on this.
So Emma has a great question. Her 5-year-old's hemangioma has gone flat, but the color is still vibrant.
Yep.
Will the laser help it?
So laser will treat the color or the superficial component of any vascular birthmark like hemangiomas and whatnot. And this is kind of when we talk about people, it's like hemangiomas don't really go away, but they slowly resolve, meaning the color gets lighter, the size gets smaller, and then sometimes they can resolve to an acceptable place where just a little bit of tissue discrepancy or a small blemish of the skin. But if the size has gone better, but the color has not, again, laser would be very effective in this type of area, and it shouldn't only, and especially if it's on the involution side, meaning it's no longer growing, but actually in the process of progressively going away, the laser is actually more effective and during that time. So it should only take 1 or 2 lasers, maybe 3.
Awesome. Elizabeth wants to know, and I've not heard this question, if timolol crosses the blood-brain barrier. She's using it on her son's scalp, and she's concerned about long-term effects.
So timolol does not cross the blood-brain barrier. It's a cutaneous or topical application, and you wouldn't treat it on an ulcerated hemangioma, and you wouldn't want to put it in anywhere where the body could get absorbed, whether it be on around, the child can't eat it, lick it, or touch it, because it's a much more concentrated version of beta blockers. So conceivably, if you had a child that got a hold of a timolol bottle, they could actually overdose on a beta blocker. So you would certainly never want to give them access to it, let alone put it in an area where an infant, who's not being watched could lick it or touch it, because they can get an overdose. But as far as applying it to the cutaneous skin, I think it would never get absorbed to any concentration. And people say, well, when do you give timolol if you're concerned about that? I say, well, wait till they go to sleep. They go to sleep at least twice a day, every 10 or 12 hours, and when they go to sleep, you can apply it then, because they're less likely to move or touch or anything like that. And that's a very effective time to give timolol.
Would you cover it with anything so that it doesn't rub off on stuff? And
so again, if you wouldn't, again, as long as it spends its time, a good 20-30 minutes on it, that's the time of effectiveness. Okay. But again, timolol is not a heavy lift. If you're talking about cutaneous scalp, I don't know that that's the right area for this. I think that's not really something that's going to be effective. Mm-hmm. So again, you're talking about typically eyelids and nose and ears. Those are the thin skin areas where I've seen effective timolol.
So lots of questions, and we're almost 45 minutes into it. Take a breath, Dr. Levitin. So Cindy says her grandchild is 18, has Sturge-Weber, and now she has a growth on her hairline. She's not sure what it is. So pyogenic granuloma.
So again, in port wine stains, there's several different things that can happen. A scratch of the skin can cause what we talked about earlier, a pyogenic granuloma, which is easily treated. But port wine stains in adolescents and teenagers, when they start to develop what we call blebs, which Dr. Linda just said is where you break the dermal barrier breaks, and so you start to get that hypertrophy or the early signs of hypertrophy. So please send a couple photos, maybe from a couple different angles. Those can be treated early with pulsi and YAG laser at the same time. That can sometimes reduce that height of that area of hypertrophy. Sometimes a small little local excision will restore it back to normal. So
Aona, her son is 3. She wants to know when you can start without anesthesia, which is funny because Dr. Geronimo starts them first with anesthesia, and then when they get older, he switches. And she wants to know about a specialist in Romania. We don't know of any. We do have a doctor that's in Poland, and then a couple in Berlin and Italy, but I don't know if you know of anyone in Romania.
Not in Romania. And again, port wine stains, I always say the size of the palm of the child is an appropriate area to treat without anesthesia in the office, maybe a little bit more than that. It's harder as a child gets over age 18 months to hold them still enough to get a really good meticulous treatment. Sometimes a little mask anesthesia can be very helpful. We followed a lot of patients over a lot of years, people who have siblings and have not seen any signs that repeated small doses of anesthesia cause any long-term learning difficulties or any effects. So I think it's really about getting the effective treatment and doing it in the safest way possible.
Thank you. So again, this is a whole nomenclature thing with using one term, and that's why I always have them tell me when it was there and how old, because we have an adult woman, Sibel Prado, who has, quote, a capillary hemangioma. Which is more important, the V-beam or the YAG? Both are Candela or the pulse dye. I'm 43, and my capillary hemangioma is on 1/3 of my face.
So capillary hemangiomas are usually port wine stains. Again, when you were 43 years old and back when you were born, they called everything a hemangioma. That's just what we talked about then. And I still see these adult patients come in to ask about their treatment for their hemangioma, which is really, again, hemangioma is a childhood illness. It's in the first year of life. And if it grows past that, it's not a hemangioma. It has to be something else. And so, yes, it's never too late to do laser. The most effective laser is the pulsed laser, and because you're an adult, you can do this in the in the office setting. You should not need anesthesia unless it's a very large area or very painful. And it will take more than one treatment, but I mean, 5, 6, 7 treatments over the next year could make just a big, big difference for you. It's something worth having evaluated and treated.
And I want to get this out there because Louisa, who wrote in the next questions from the UK, I will be in London next month in November, around the 13th, 14th, 15th with Dr. Tom Brees.
Oh, good.
And we are willing to meet with any families. I'm going to post it on our website, share it to all the groups. The most we can do is like at least give an opinion.
Mm-hmm.
So she's saying her son is 2 and they were told the hemangioma would be gone by now or reduced. But she's saying he's having a lot of infections and ulcerations and it's on his forehead. And there are no treatments in the UK. There are nowhere to remove it. We get this weekly, nothing available in the UK.
So unfortunately, they have laser in the UK. I'm not familiar with any surgeons who are doing, I'll say, aggressive surgery, meaning that, for larger areas. I've had my own patients travel to New York for these treatments, and we certainly have a international program at my hospital to be able to bring these patients in who may not have insurance coverage to do special arrangements. Please reach out to me by email. I'd love to see the photos and give you some guidance. If you're expecting this to go away, I'll be glad to give you my opinion whether or not this is realistic. It sounds like this has infections and ulcerations. You also have scarring, and scarring doesn't go away. And so there's a large hemangioma and a scar at a young child who's age 2. It's a great time to consider surgery. Children develop a psychosocial awareness or awareness of their differences starting at age 2.5, maybe a little younger, a little older, and that's when they start getting into older age social circles where other children are noticing differences as well, sometimes pointing at things. It's usually not till age 5 or 6 where kids start to really identify differences as being not a positive experience. So this is a great time to have this discussion, to talk about treatment options. We certainly, again, would be happy to talk to you directly afterwards through email.
And also the Grand Ormond Street Hospital has a vascular anomalies program, and I have the email of the nurse in charge of that program if you're interested. So Jessica is saying her daughter's almost 2. We've tried weaning her off of propranolol twice, and it grows back. When is an ideal age to wean off? And I just want to make a comment, and you'll probably comment on this, but I just was in communication with our liaison from the American Academy of Pediatrics, Dr. Buddy Cohen from John Hopkins, and he says you can't do it slow enough because they're just weaning them off so quickly. They're trying to come up with a formula now. So for however long it grew, it needs 1 month or something each.
I do a month-long step-down therapy, and the reason why is because about 10 to 15% of hemangiomas that are treated with propranolol that block the growth, meaning and potentially reverse the growth, that were effectively treated with propranolol, you want to keep them on until they're past the growth phase, meaning 9 to 12 months of age. And then you want to do a slow wean, and the reason why is because you want to catch the ones that regrow. And if you can catch them as they're starting to regrow and go right back up to the dose that they were on before, you capture that, and they actually get right back, the same effectiveness. And so by doing a slow wean over 4 months, where you're not just dropping it in half and whatnot, but through a slow weaning process, you're really evaluating them critically during that time to really make sure that they don't have to be on the propranolol any longer than they have to be, but also making sure that we maintain that clinical effectiveness that was the whole reason why we treated in the first place. So it's very important to always be critical while you're on it to make sure it's worth staying on it, but also while you're coming off it to make sure you don't need to stay on it longer.
So Heather's talking about getting laser in Pensacola, and I actually have 2 experts on our website from there. Yeah. So email me, and if they don't accept your insurance, we have some that'll do a flat fee payment, Heather. So email me about the 2 doctors in Florida. And
we also want to remind people that vascular malformations are not cosmetic surgery or cosmetic treatments. These are vascular malformations that took normal tissue and created an abnormal tissue. So it's very important to recognize that you may see a laser specialist who may do more cosmetic work, but in my experience, these are things that are covered by insurance. It may take us a little extra effort, a couple extra phone calls, but it's very important we're treating an abnormal condition to restore it back to normal, and that's called a reconstructive procedure or reconstructive treatment. Reconstructive therapy, and it's very important to use those important words when communicating with insurance companies.
Absolutely, thank you for really reinforcing that. So Femke is from the Netherlands, and she has a VM in her lower calf, and
Mhm.
she's having a problem with her knee. And again, if you will email me, because Dr. Laurence Boone's team is right.
Sure.
They do a lot of work with the Netherlands
Yeah,
and
that's great.
Belgium.
That's great.
I mean,
So
if you want
I'll
to
just say,
address
like,
the problem,
compressive therapy, I mean, compression sleeves, neoprene sleeves, or compression stockings is very important for extremities, because when we stand up, the blood pools. That's when you get dilation, and people with KTS have a more exaggerated version of what you're describing. Behind the knee is an area where you can also have painful swellings. I think, again, an MRI evaluation of the entire extremity from the hip to the toe is important to see the full extent of this. Our colleagues who do sclerotherapy have done amazing things for people in pain. Again, you're talking about stretching of tissues that most typically involve the musculoskeletal tissues that have, again, these fibers on the fascia that trigger pain. And these are people who often require daily pain medications just for daily walking activities. So it's really, for a dancer who I'll call you, a very active person, I think it's very important to have this fully evaluated for the depth of the area, for the area involved. And again, an MRI is a great first step for that.
so Lisa, oh no, wait, Emma says her daughter weaned off of propranolol at 1. Her larger birthmarks all rebounded. The one that worried the dermatologist under her eyelid stayed away, so they let things to go away on their own. Now she's 5 and about to start swimming. So I plan to look into Timolol, but that won't work, right?
Timolol's not going to work for that. Again, I'm happy to review your photos to show you what's possible. Again, 5 years old, has it gone away good enough for her to go to school now with other children? Is there other treatment that could be done? Absolutely. And I would say on a case-by-case basis, we will look at this, whether it be laser therapy, even a small surgical therapy that could touch up some areas that are still not, as you said, gone away completely. But it's important, as they are approaching school age, to be critically evaluating which patients still need treatment for this.
Yep, thank you. We're down to 8 minutes. Can laser on the scalp for a hemangioma lead to hair loss?
So the pulse-side laser does not cause hair loss. The hemangioma does. And what happens is when a hemangioma raises, it separates the cutaneous structure from the hair follicle. And when they lose their hair bearing follicles, they don't regrow. So again, the laser does not prevent the hair growth. It's actually the hemangioma, which again replaces that dermal area where the hair follicle is. And unfortunately, so if you were to let that hemangioma, go away in 4 or 5 years, the hair does not regrow into that damaged skin. It actually is something that has to be removed. And once we recognize that there's a bald spot or an alopecia area where hair will not grow, and certainly if it's large enough where a strategic comb over is not going to cover it, or if it would grow older and still be present, those are indications for surgery, and that's a disfigurement. That's an abnormal change to the skin. These are covered by insurance. These are outpatient 1-hour procedures. Typically for most of these patients, you can bring the hair-bearing skin back together with a small little scar down the middle, so that it's not even visible even to a hairstylist when they're later in life.
So Lisa has a good question. Her daughter has extensive port wine. She says it's reticulated on the arm and the back. Could be CMTC, who knows, port wine. She said the ultrasound ruled out that it was KTS, but now the little girl is complaining of pain.
How old is the child?
2.
So I think that's a time to reevaluate. But when the symptoms change or the malformations change, get another MRI, because a port wine stain can be overlying an underlying vascular malformation. There's other types, KTS being the most common one. But you're really questioning is the port wine stain the issue, or is the underlying malformation the issue? And that would require, again, measurement of the extremity, see if there's any discordance growth between one side versus the other, and again, determining if there's something deeper into the underneath the skin. And then again, an MRI with contrast is the appropriate study.
Okay, as we're getting down the finish line, I think Tovar Ida will have to email you pictures. He says his son has a hemangioma on the upper lip since born, and they've done sclerotherapies. Is there anything else that can help remove it?
So if you're using sclerotherapy,
if it was there since birth,
I would say if it was there since birth, I'd question the diagnosis if this is a venous malformation. And yes, surgical debulking of the upper lip can remove a malformation. I've had children that have had sclerotherapy, but again, it only just shrinks the vessels and doesn't remove them, where we can remove that source of that malformation. And I've seen this even in teenagers where it's recurred. And if we can remove it, you can potentially give potential cure or lifelong control. And a child who's developing the malformation often grows with the child during these pubescent growth spurts. So, you're looking at something now, it could actually grow bigger if left untreated or not treated effectively. So please reach out with email with photos. Let me see this, and I'm happy to give you my advice.
Great. Emma, there is a doctor at Alder Hay. I have her information. I don't have it up off the top of my head, who is in London. So if you email me, I can get you that. Kyla Manny is saying hello. Her third son had a hemangioma, so now she's 3 for 3. She's our hemangioma mama winner.
Go to Vegas.
Yeah. She said, is there any age that's too late to start the timolol?
So again, timolol is never too late to try as long as it's thin skin in a thin-skinned area. And again, that's going to be the eyelids, the nose, and the ear. I don't know that it's going to work in any other area.
Okay, so Damaris is worried, can the laser cause cancer, or is it okay for the baby's birthmark?
Absolutely. The pulsed lasers are basically absorbed in the dilated vessels. It does not communicate or carry anything from the cutaneous under the skin. It does not penetrate that way. It is not going to cause any cancers.
Aaron wants to know if you have, we're getting down to the wire here. We have a lot of questions. Your thoughts on sirolimus?
I will say that is a long discussion on a case-by-case basis. Sirolimus is most effective in lymphatic malformations, particularly microcystic disease, where it's hard to find other effective treatments. It can stabilize the disease. It can sometimes shrink the involvement of the areas. It does have side effects. It does make people potentially at risk of infections. We're talking about children who are exposed to other children, and I'll just use that as the framework of a discussion on a case-by-case basis that I'm happy to have with anyone.
Is bleomycin good for a port wine stain?
I would say that a bleomycin is effective in dilated venous structures such as venous malformations or potentially lymphatic malformations, potentially arterial venous malformations in the venous component. But because of the size of the vessels of the port wine stain, I don't think that would be an effective treatment for that. Not in my experience.
Okay, wow, we're getting 3 minutes. Brittany says her daughter had a minute or two, had a biopsy. They just had the results are type 2.
Yep.
Are there any therapies or medications for this gene as of yet?
So TIE2 is the genetic component of hereditary venous malformations. So that family often has other family members that they can see, and it can be male and female. It's not just one side or the other. And so that is not a gene that we have a therapy for. It's just a marker of being able to diagnose people who have potential genetic transmission of the venous malformation. The treatment for the venous malformation is the same as the other non-genetic, which is the most common, sporadic or non-genetic components. And those are the patients who need to be evaluated for the extent of the malformation. Cutaneous structures can be treated with laser. Deeper structures can be treated with sclerotherapy and or surgery. Again, symptomatic treatment and a case-by-case basis.
So Lucy wants to know if the laser will scar her baby after she has the treatment.
If which will scar?
A port wine stain. A laser will laser scar.
No, that should not happen. Occasionally you could have a blister that may occur. You treat it topically with some ointment, and that should not have any scarring. That would be an unusual occurrence if ever.
Do blood clots travel in venous lymphatic malformations?
So it depends upon where it's at. In lower extremity venous malformations or venous lymphatic malformations, that's certainly a small risk. You'd have to meet with have a evaluation by either a interventional radiologist or a hematologist to discuss whether or not there's risk to you for those depending upon the size of the vessels. And again, low-dose aspirin therapy can be the most effective, just a precautionary measure. Sometimes compression stockings, particularly on long flights or anything like that, or nighttime where you're laying flat or still.
So Cassie wants to know if an anticonvulsant and propranolol can be taken at the same time.
So we're talking about seizure medication, anticonvulsant for like childhood epilepsy and propranolol. And I would say that it's probably on the second page of a data sheet that I would need to review. I haven't had to ask that.
I think she could ask Dr. Comey, our neurology expert.
Absolutely.
Yeah.
Ann Comey is actually our Sturge-Weber expert who treats
seizure
and neurology, has a full, first of all, if your child has Sturge-Weber, please reach out to Dr. Comey. She has a great database, a lot of helpful information, a lot of newsletters that go out to these families, gives them a sense of community because it's often a much more difficult childhood evaluation and treatment. And so absolutely, that's a great question that we can forward to Dr. Comey.
Okay, a couple more. So Heidi wants to know if a birthmark is located in the arm, is it more difficult to treat for a laser for a port wine?
So extremities are more difficult than other parts of the body on the face, neck, or trunk. And it just depends upon the extent of it. If it's a localized area, it's much easier to treat. If it's the full area, like a gloved hand, it's much less effective. And that's something that just, you want to have realistic expectations. You understand that you're going to be treating something multiple times, and sometimes you have to start somewhere, and you treat 4 to 6 times over the course of a year. Take photos and reevaluate. Have we made 20% improvement? Have we made 50% improvement? Have we made no improvement? And I think that would guide whether or not future therapy would be indicated.
A couple want to know what your email is, so if you want to say that
Sure.
while I'm getting ready to just.
So my email is on my website. If you Google my name, but it's Dr. Levitin. That's DRLEVITIN at birthmarkcare.com. My website is birthmarkcare.com, which is a Ask Dr. Levitin page where you can click there. You can attach photos, provide some clinical information. That's www.birthmarkcare.com. And also, I am listed on the front page of the birthmark.org Vascular Birthmark Foundation website. That also forwards directly to my email. And I also have a Gmail for those people internationally who may not have as easy access. That's Dr. Levitin, DRLEVITIN at gmail.com.
So last question. Lena says her 4-month-old has what the doctor said is likely a hemangioma in the middle of his forehead. I tried to get a dermatologist appointment but can't get in for a month. Is it worth seeking a different doctor in order to get in sooner?
So 4 months is in that time where the hemangiomas are growing, and this is the time we want to start treatment. So I would say is I would call that office every day and ask for an emergency add-on, a cancellation. I'm available. I would reach out through email to myself or any other experts on the website, on the birthmark.org website. We are all available. The most important thing is to know is do you have the luxury of time? Is this something where we're going to watch it closely and just go see an expert? Or is this something that's growing, where it's growing sometimes by the day, by the week, and maybe even oral therapy with propranolol or hemangiol is indicated? Maybe a laser therapy would change the entire course of this if we started therapy now. And I think this is one of those times where you have to use time as of the essence. And I think it's very important to have information and a diagnosis as early as possible because it will greatly affect how we treat these patients.
And I've been known to call a few to get people into, so they can also contact me and say, our expert said this needs to be seen right away. So thank you, everybody, for a fabulous non-stop, amazing session with
great questions,
Dr.
and thank you
Levitin.
Everyone for logging on today. This has been a pleasure.
Yes.
It's my second time back, and I hope we can do it again.
Next month, the day after our conference on October 13th, Dr. Beth Drolet, who is the leading cloves expert, overgrowth syndrome, extremity lesions, will be going live with me. That'll be on Sunday morning. And then in November, we will have Dr. Ann Comey for our Sturge-Weber syndrome session. So thank you all. And remember, Dr. Levitin's email and mine are posted. You can review and watch this again as many times as you want. Share it on your websites. And thank you and have a great month. Thank you, Dr. Levitin.
Thanks, guys.